Our next speaker is Dr. Charles Gatt. Dr. Gatt is a board-certified, fellowship-trained orthopedic surgeon at University Orthopaedic Associates with a subspecialty in sports medicine. He is the chair of the Department of Orthopedic Surgery and a clinical associate professor at UMDNJ Robert Wood Johnson Medical School. He is also the program director of the Limb Salvage Program at AFIRM and a team physician for Rider University. He is actively involved in clinical research in orthopedics, is a frequent lecturer on various orthopedic topics, and has authored numerous textbook chapters and articles in scientific journals. Dr. Gatt.
Well, thanks for having me here today. I've been asked to speak about adolescent overuse injuries. And I have an interesting perspective on this, and it's not unique because I know a lot of people in healthcare have the same perspective. But obviously, as a sports medicine orthopedic surgeon, I see overuse injuries in my office basically every day that I'm in the office. So I see them as a physician. Up until 2 years ago, I was also a youth coach, and I coached football and basketball and baseball, since I have 2 boys. So I got to see the athletes, from the coach's perspective, and saw these injuries come up. But also because the other parents knew that I was an orthopedic surgeon, I was like the team doctor, which wasn't so great sometimes. And then finally, I have 2 boys who have played sports, their whole adolescent lives. Now they're in high school, so they're out of my hands and in your hands. But I've got to see it from the parents' perspective too. And when I look back on the topic of overuse injuries and maybe how I've addressed them, wearing my different hats, I realize that I've probably been somewhat inconsistent in even how I would address these injuries. So it's a kind of an interesting topic for me to talk about. So first of all, overuse injuries. I think the point that you're going to see that I drive home this afternoon is that overuse injuries in our young athletes, adolescents, is really a big problem in the United States. So looking at some of the epidemiologic data that's out there, we know that about 30 million kids are participating in organized sports in the United States. And we know that the participation in high school athletics is increasing. High schools are adding more and more sports all the time, and now they say the estimate is 7.3 million high school students participate in sports annually, so that's a big number. The thing that I think is very striking, probably to all of us and everyone who's involved with youth sports and overuse injuries, is that we see these younger athletes specializing at a very young age. I can think of many examples of kids in my own town and my son's friends, like a boy who was in 6th grade who was a very good all-around athlete, and by 6th grade had decided he was going to be a baseball pitcher and had his own personal coach who was pitched with him once a week, in addition to him throwing with his dad every day. So he had given up all other sports and all other positions and was just a pitcher in the 6th grade. I thought that was a little crazy. Then finally is the opportunity for the speed and agility training. So these opportunities have absolutely exploded. Private companies, orthopedic practices, physical therapy practices, all offer ways to make your kids bigger, better, stronger, and faster. What goes on with it, though, is that these speed and agility opportunities aren't during a season off or instead of a sport. They're in addition to the sport that the kids are playing. So they're on a rec team or a travel team or a rec team and a travel team, and they're going to speed and agility training. So the amount of time that kids are putting in sports is just outlandish in certain cases. So with all this increased participation in athletics and training and subspecialization, it's resulted in problems. So again, going back to some of the United States data that we have, we know that more than 3.5 million children under the age of 14 are treated annually for sports injuries. So that's under the age of 14, and that's before high school. That's a pretty big number. If we look at high school and middle school injuries, overuse injuries account for at least half of the injuries that are being addressed by athletic trainers, by the primary care doctors or sports medicine specialists. And if you look at the number of doctor visits and hospitalizations, 500,000 doctor visits for high school athletic injuries. Out of 2 million injuries, 30,000 hospitalizations. I mean, these are kids, if you think about what their goals are, hopefully we're all trying to promote healthy lifestyle. I know there's a lot of high expectations for the kids, but look at number one, the burden on the healthcare system, and probably the harm that we're doing to our kids, if this is what is coming out of all their high-level participation in sports. So when I look at overuse injuries, I kind of break it down into three groups. There's skeletal injuries, which involve the osseous system, stress fractures, which I think is the most commonly addressed problem. Not as common as stress fractures, but growth plate injuries you also see not infrequently in these young athletes, because again, these are pre-high school or early high school kids. They're actively growing. They're in their accelerated phase of growth, and they're working out hours and hours a day. And I'll go over some examples of how the growth plate injuries can lead to problems. Then there's soft tissue injuries. So again, we'll see tendinopathies in young kids, patellotendinitis and things like that, and then chronic muscle strains. Kids come in with aching and they can't play anymore because their muscles hurt so bad. And then the apophysitis injury, which is really has a lot to do with growth. It's kind of a mixture. It's the tendinous insertion onto the growth center of bones, and that also is a pretty common problem that we see. Actually, probably one of the most common that we see. So let's start off with stress fractures, which I think that's been something that we're all well aware of, but it's been studied relatively well in the collegiate population. If we look at a study out of Lafayette looking at 1AA athletes over 2 years, 6.9% of the females developed stress fractures, 2% of the males. And another Division I program, they looked at the track, running stress fractures, and this was a prospective study of 111 athletes, 21% incidence of stress fractures, and they kind of came up with a risk ratio of 0.7 stress fractures per 1,000 training errors. But if you look at the dates of these, they really occurred back in the early 1990s. Over the subsequent years, there have kind of been repeat studies. The numbers vary, around 6%, 10%, 20%. It's hard to say what the real number is, but I think it's well accepted that collegiate athletes deal with stress fractures. Probably one of the better studies that I didn't put up on a slide was one that came out of the Big Ten that tried to look at some of the risk factors associated with stress fractures in collegiate athletes. And like two that stuck out to me were they were most common in freshmen and sophomores, which makes a lot of sense because kids from high school are now moving up to the next level. They've moved to a new level of intensity of training, and their bodies may not be ready for that. And also coaching changes was actually a very big risk factor, because a new coach comes in with a new philosophy on how to train, and that may change people's readiness for that level of participation. So again, even though we have all these studies about the incidence of stress fractures in college athletes, I don't really think we have any good data on, number one, how to treat them, or number two, how to prevent them. But if we look at our pediatric population, adolescents and high school, junior high school kids, there's really very little data, if any, that's reliable. And I think, to me, this is probably the best study that's come out in, after I've done a lot of review of the literature. And this was published in 2011 in the Archives of Pediatric Adolescent Medicine. So this is a study group called the Growing Up Today Study. And the study group is actually made up of the kids of nurses who participated in another health study group. So there's a big epidemiologic system that's able to generate all this data. So the goal of this was to see if they could identify some of the predictors of stress fractures, and they did a subset of adolescent girls during a 7-year period. So this 6,800 girls were involved in the study. They followed them twice a year, so they collected data on the girls every 6 months for 7 years, and they ended up coming out of the 6,800 girls, 267 girls developed a true stress fracture. That's an incidence of about 4%. And that's probably one of the first studies that ever shows true incidence data, because it's very difficult to calculate incidence data. You can calculate occurrence data, take a cross-section of the population and say how many of our athletes have stress fractures, but incidence, like what's the risk of developing it as you participate, is a number that's really hard to come by. So the conclusion was that the girls that participated in relatively high-impact sports, running, basketball, cheerleading, and/or gymnastics, because basically they're about the same these days, should be encouraged to take some time off and get involved in lower impact activities. It's a pretty interesting article. They actually looked at the mother's history of osteoporosis or low bone mineral density, tried to see if there was a genetic correlate to the girls, not that they were able to calculate those numbers in the girls, but they showed a trend towards mothers who had lower bone density, their daughters having higher risk of stress fracture, but it wasn't statistically significant. So I think it's a lot of data, and I look at this as a study that's an example of where we really need to go with a very important topic. You know, over the years, I mean, I've said this many times when I've stood up and talked, but I've been very fortunate to be able to work with Eric because he's the energizer bunny of stress fractures. I mean, the guy knows as much about them as he knows about ankle sprains, and he really has a tireless attitude towards trying to make this diagnosis. And it was his brainchild to come up with a stress fracture registry, and he created a whole online system of being able to enter data about our high school athletes that have stress fractures. So these were all high school athletes. 75 athletic trainers contributed to the data. The trainers were actually from 11 different states. It was an online database, and entering the data was relatively quick and easy. It took no more than 5 minutes. So after about 2.5 years, we kind of put the brakes on it and said, let's see what we have. And in that time, there was a diagnosis of 230 stress fractures in 189 athletes from the 57 high schools. And this is actually probably the biggest reported study in terms of occurrence of stress fractures in adolescent athletes that's ever been reported. Not a lot of it was surprising. Track was the most common. 48% of the stress fractures occurred in the tibia. It seemed like the younger athletes had a higher incidence of stress fractures or a higher occurrence of stress fractures, and their injuries seemed to be more proximal tibia, things like that, whereas the older athletes, for whatever reason, seemed to have a little bit more distal symptoms. And one of the facts, and again, this is probably a known fact, but we picked it up with our occurrence data, that one of the biggest risk factors for developing a stress fracture is a history of a prior stress fracture. And so almost 20% of the kids had a history of a prior stress fracture, and now we're coming in with a new stress fracture. It wasn't a recurrence of the old one. So we all see stress fractures. We all struggle with how to treat them. And the truth of the matter is we really don't know a lot about them. There's just not a lot of data out there. I think, one of the common misconceptions, because most of them are in the tibia, everyone calls them, they say they have shin splints. I've always been absolutely opposed to the term shin splints. I don't know what it means. It makes no physiologic sense. It makes no anatomic sense. But in any event, I've tried to get all my patients and parents and trainers I work with to never use that term. So when kids come into the office and I diagnose them with a stress reaction of the bone, because a lot of them don't ever meet the true criteria of stress fracture, the parents are like, well, why is this happening? And I say, well, we really don't know, but let me give you my take on it. So I'll tell you what I tell the parents and the kids, because I think if they kind of understand my philosophy on it, they'll understand why I make the treatment recommendations that I make. So I'd say, every day that you're out running and jumping and playing, you're causing microscopic cracks in your bone. When you go to bed at night, your body heals them, so you don't know about it, your body doesn't know about it. It's kind of the way life works. But usually due to either a rapid or abrupt increase in the intensity or the duration of your workouts, now you start causing more microscopic cracks and your body heals at night. And so maybe for the first week, you say at the end of practice, my shin really hurts, but I walk it off, I feel pretty good. Now it starts to hurt in the middle of practice, and before you know it, the first few steps you take, it's hurting, and then next thing you know, you're limping around school. And that's because you're falling behind. You're causing more micro trauma to the bones than you are healing when you give yourself a period of rest. And I think that period of rest is one of the key points that I try to drive home. But why does this happen? Because if we look at the physiologic strength of bones and the physiologic loads on the bones that occur, running and jumping really doesn't generate enough force to cause fractures in the bone, and yet we're seeing these, these stress fractures occurring. So my only philosophy is that it's some form of an exaggerated metabolic response. The bone's trying to remodel in response to these forces that are being applied to the bone. It actually leads to probably accelerated bone resorption, maybe more osteoclast activity, but we really don't have an answer to why people develop stress fractures. One of the interesting things is that the majority of stress fractures the vast majority occur on the compression side of the bone, and bone is strongest in compression and weakest in tension. And that's where we see 90% of stress fractures. So again, physiologically, the concept just does not make sense. So, how do I, my diagnosis, truthfully, the majority of my diagnosis of stress injuries is based on history and physical. I asked them a lot about their training routine, have they had any sudden changes, things like that. I examine them, look for points of tenderness, And I think in this day and age, especially, with the quality of athletic trainers getting kids into the office, we do see them early enough that it's relatively uncommon for the stress fractures to show up on x-ray. So most times I do x-ray as part of the routine workup, but that's negative. So then the question is, do I get an MRI? There's a lot of reasons that I get an MRI, some in terms of whether I want to determine if I'm going to let somebody go back, some to quiet the parents down, some to prove to the parents that there's something wrong with their kid and it's not just growing pains. But in any event, there is a grading system. So if you look on the left, a grade 1 reaction is a periosteal edema. Grade 2 would be endosteal edema. Grade 3 would be a combination of periosteal and endosteal edema. And then finally, a grade 4 on that tibia, there's actually a fracture line through the medial cortex of the tibia. So now we have this MRI that documents a stress fracture, and the question is, what do you do with that? Well, the truth of the matter is, the grading of the stress fractures gives us no predictability in terms of the severity of the stress fracture. In other words, is it going to go on to a complete fracture or the duration of the symptoms? So I can look at these things and I can inherently, from like a gut feel, use them as guidelines about how quickly I might get somebody back to play or whether I'm going to let them play. But there's no hard and fast criteria. I can't say because of this, because you have a grade 2 stress fracture, you're out for 3 weeks. That data does not exist. So how do I handle treatment? I think the truth of the matter is most people handle stress fractures, very differently. And I think personally I'm very aggressive in terms of letting people play with the majority of stress-related injuries that I see to the bone. So if someone comes in, with stress symptoms, they're not terrible, and I take a general x-ray and the parents are calm and the kids aren't limping around my office, I get an x-ray and it's negative, I'll tell them, look, you're probably at the very early stages of a stress reaction. Modify your activities, cut back on your mileage, only do 5 suicides instead of 20 suicides, but somehow you've got to cut back on your activity. And if we can let you participate to the point where you're getting a little bit better each week, or in the worst case scenario, not getting worse, we can probably keep you on the field. And that tends to keep the majority of people happy. If they're x-ray negative and their MRI is positive and it's getting a little bit higher towards the grade 3 range, I'll say, look, this is a little bit worse. And again, it has to do a lot with how I perceive their pain when I'm examining them. I say, we can still keep you out there, but at this stage of the game, it's competition only. So if you're a soccer player, only play the games and don't practice, if the coach will allow that. If you're a runner and it's the end of the cross-country season, it doesn't matter if you run the last 2 weeks of practice. You just need to race, and that's all you have to do. So there are other ways to maintain aerobic training, pool running, non-impact aerobic training, emphasize competition only. But I tell them that the key is the symptoms cannot worsen, because if the symptoms are worsening, obviously the concern that I have as a practitioner is that ultimately they'll take this stress reaction or stress fracture and turn it into a complete fracture that requires reduction, maybe surgical treatment or mobilization, whatever the case may be. And I try to emphasize how important communication is, because a lot of these injuries are occurring. We get 2 kind of peaks. 3 to 4 weeks into the season, when the kids who did nothing all summer beat themselves into shape, then everyone's got a stress reaction. And then towards the end of the season, when now they're just completely worn out, but they need to run in the states or play in the county tournament, and communication is so key. You got to tell the kids, you've got to tell your trainers if you're getting worse. You can't hide your symptoms. You got to say the reason you can't hide your symptoms is this could turn into something worse. That could potentially even be a career-ending injury. So my office visits with stress reactions or stress fracture patients are really relatively long office visits with a lot of talking, and a lot of talking trying to engage the parents into the whole discussion. If I have an x-ray positive, there's a fracture line, or they have a grade 4 MRI, then all bets are off. They're out. I put them on crutches, protective weight bearing, whatever the appropriate treatment for those stress fractures are. And these are for the common medial tibial stress fractures, things like that. There are high-risk stress fractures, and these are the ones that you have to look out for. So when someone comes in, an endurance athlete comes in and they have groin pain, I'm always getting an x-ray. And if I'm convinced, if the x-ray is negative, I'm probably going to send them for MRI, because my concern is a tension side stress fracture, which is on the superior aspect of the femoral neck. If you see that, that actually requires surgical treatment, and it requires surgical treatment almost in an urgent fashion. And the worst story I've ever seen about one of these, it wasn't a kid, thankfully, but a guy had a tension side stress fracture. The guy ended up going home and walking on crutches and fell down the steps and had a displaced femoral neck fracture. Ended up trying to fix it. It went on to AVN, and he ended up with a hip replacement, and he was 30 years old. And that was 20 years ago. It's just, he's probably in his second hip replacement already, and now he's, 50 years old. The anterior tibial stress fracture, you think of all the shin pain that you see, and most of it is, I don't know what happened there, but most of it is, medial, posteromedial pain, but I examine very carefully along the anterior tibial crest. And if they have pain there, if they have pain when they jump and their pain's in the front, I'm going to get an x-ray and look for the dreaded black line, because the dreaded black line, that's that line that goes through the anterior crest of the tibia, that's the one that's going to just snap. You've seen it in soccer goalies who have it, and they go up to block a shot, they come down, tibia just snaps like a piece of chalk. It's just a fracture just like that. So those are dangerous fractures. They need to be treated very aggressively. And I think not at the high school level, but certainly at the collegiate level, high level, you'll see a good number of those treated with IM nails just to get it over with and get the kids back to sport. And then finally, the fifth metatarsal or Jones fracture is probably the most common of these high-risk stress fractures that we see, and we pretty much treat those with screws. So most of those require surgical treatment. One of the other ones that I put in as a high-risk stress fracture is the femoral shaft stress fracture. So I told you about letting kids run on stress fractures that are MRI positive, X-ray negative. I don't do that with a femoral shaft fracture, because I have seen over the years femoral shafts just crack with a stress reaction in the bone. So I tend to be much more conservative with those and say, I don't make them go on crutches, but I take them out of running for at least 4 weeks if I diagnose a stress fracture in the femoral shaft. So I'm going to just go over an interesting case, and I think this kind of points to a lot of the problems that I've described in terms of, lack of diagnosis, delayed diagnosis, and things. So this is a 16-year-old girl who plays soccer year-round. She runs winter track, she runs spring track, and she swims. So I don't know, and she's a genius. So I don't know how she does all that stuff, but she somehow knows how to do it. So during her sophomore year in high school, she started developing worsening right foot pain, and to the trainer's credit, he's like, you really should go see a doctor. Didn't want to see a doctor, just wanted to play through the season, and this was actually during track, but she was also on one of those fancy soccer clubs. So finally, after she's limping around, her father brings her in to get an x-ray. It's negative, but she hurts right over her navicular, and she has a navicular stress fracture, which again is a high-risk stress fracture. Now, this is very lateral, and it's not your typical navicular stress fracture. A lot of these we fix internally with a screw, but for many reasons, I'll tell you, we treated this non-operatively in a cast and non-weight bearing for about 6 weeks. So she got better with non-weight bearing. Her pain went away. She started to walk on it more gradually, and it looked like we were going to probably get her back to soccer, but it was going to take a minimum of 2 months, maybe more. She had an incidental injury to her contralateral foot. She never had any pain in that foot before, and it wasn't even lateral foot pain, but we got an x-ray of her foot, and you could see she's got a beak on the fifth metatarsal laterally. Pressed on it, no pain. It's not hurting her. Kind of assumed through, taking it with thorough history, it's probably a healing stress fracture. She's not running anyway. Don't worry about it. This will probably continue to heal over time. So great, everything's good. So girl gets better, goes back now to her club team. Now she's getting ready to be in showcase camps. So she's got to be ready for the summer to go to these showcase camps. So we have an MRI that shows that her stress reaction in the navicular is gone and that there's no edema in the bone, but she's got a true non-union of the navicular. But it's asymptomatic. She's running, playing great. Parents don't want to do anything, and truthfully, again, there's a lot of technical reasons, but it's probably not the best thing to operate on, so we left it alone. So she's doing well. Well, in June of this year, she's at one of these showcase camps and just tweaks her other foot, the one with the fifth, a little bit, but it gets better in one day, so parents don't bring her to the doctor because she's got 2 more showcase camps before the summer's over. Well, last weekend, she's at her 3rd showcase camp of the summer, rolls her foot a little bit, can't walk, and now she's got a displaced fifth metatarsal. So that little beak that was there, it was actually now 9 months ago, finally completes itself. And if you think of this girl's history, ignoring symptoms, wanting to play in showcase camps, all the things that we talk about. So I actually just fixed her, put a screw in that to get that to heal, because now she's worried about her ability to play in the next upcoming soccer season. And it's to me, like I look at this and say, it's hard to believe all this continues to go on. And it's amazing because the parents want her to play and she wants to play. And there's no end in sight. And I don't know what the next injury is going to be, but there will be another one. So when I look at stress fractures, which again I think is much more common, there's a lot of need. I mean, I think we basically know how to treat them, but we don't know how to prevent them. So we actually do need some hardcore incidence data. And it's only, with people like the energy of Eric who are going to put together, multi-institutional databases, because, the numbers aren't that high. You need a lot of kids and a lot of injuries to actually, come up with some statistical data. We need to come up with risk factor data. I mean, how important is diet? How important is, the rate of growth? How important is the menstrual cycle? Because I can give you papers from the military, the Israeli military, they'll say answers to both questions, that your menstrual cycles have something to do with stress fractures and your menstrual cycles don't have something to do with stress fractures. So we really don't have any good answers. There's no animal model for stress fracture. We can't study the physiology of a stress fracture. We don't know how to do it because we can't make one in an animal yet, not reliably. So, we need to come up with treatment protocols. I mean, if we had data, could we say, well, for this particular injury, you're out for 3 weeks, you can go back at this pace. Everyone's treatment protocols are very random and personalized, and most importantly, all this data would finally come together for preventative strategies, and truthfully, I don't think we really have, hardcore preventative strategies. So I'm going to now just shift gears a little bit to physeal injuries, something that you would be very concerned about. So it's the same concept of a stress fracture, but now instead of occurring in the shaft of a long bone, it's now occurring at the growth plate. And it's the problem with the physeal injuries is there is the potential for growth disturbance. So, for instance, little league shoulder, is an injury to the growth plate of the proximal humerus. What do we know about kids who have pitched most of their adolescent lives? They have more retroversion of the humeral head in relation to the humeral shaft than the general population. So the truth of the matter is, with those thousands and thousands of throws, they've affected the growth of their humerus so that their humeral head is rotated more posteriorly. That's a shear type of injury. The distal radius growth plate is certainly at high risk in gymnasts. And if you look at the incidence of ulnar positive variance, meaning that the ulna is longer than the distal radius, in gymnasts, it's a higher than the general population. So all that landing from the vaulting and everything they do, the fact that they're amenorrheic, whatever, how many ever different factors you want to throw into it, their wrists are going through growth changes because they're competitive gymnasts. And then again, going back to little league pitchers, you have medial epicondyle, where you have widening or pain along the medial epicondyle. And these kids, if they, you see these kids who fall down and put their hand out and they pop their medial condyle off. Well, it doesn't happen in most kids, but the kids who are, hard throwers, gymnasts, people that post up on their elbow, have a higher incidence of these injuries. So here's just an example, and again, this is one of my son's friends. So at this time, he was 14 years old, baseball pitcher, rec league, travel league, the whole thing. And here's, he comes into my office, and he can't lift his arm above 80 degrees. And his parents are like, what do you think is wrong with my son's arm? No trauma? Well, of course, he's got little league shoulder. I didn't even need to take an x-ray, but he took an x-ray. Look at the physis on the lateral side of the humerus. It's wide, way wider than it should be. Not even close. But his parents are like, well, when do you think you'll be able to throw? I could just see, like, they want to know, when is he going to get back? So I said, let's just get an MRI. Look at the edema around the growth plate in his humeral head and extending all the way to the medial side. I mean, in the worst case scenario, this could lead to a growth arrest of the proximal humerus. That's, exceedingly rare, but it's possible. Again, so why did I get an MRI? I don't need an MRI in this kid, but I was able to show this picture, which is actually, it probably doesn't show as well on the slides. It's pretty dramatic for his parents to see all that bright white. I finally say, look, your son really needs to stop throwing. Like, we're done. We're done for, the season's over. He's out for 6 weeks, We'll let him calm down and then get him on rotator cuff exercises. And he ended up continuing to play baseball, but his pitching day, that was actually the end of his pitching days. Then the other thing is soft tissue injury. So I don't see as many overused soft tissue injuries in kids as you might think, but they are there. I think the most common is patellar tendonitis, especially in jumping athletes. The basketball players have a lot of pain at the inferior pole of the patella. And again, a girl came into my office, last year, and she had patellar tendonitis symptoms. And it was I took the history and I knew exactly what was going on, examined her. So the first question I asked her mom after I was done with all that, I said, so how many teams does she play for? 3. So she played for 3 basketball teams simultaneously. So sometimes I'll just try to go to the parents a little bit, say, so does Coach A know what Coach B does at practice and Coach C know what Coach A does at practice? I mean, and they understand my point, that they're just running their kids into the ground. So what's the answer? Don't play for 3 teams. So I can send her to therapy and tell her to do ice massage and all those things, but the bottom line is she's doing way too much practice, too much basketball play for a girl who's, at that time was 15 years old. I do see a lot of rectus tendonitis in soccer players because of the kicking motion And also, surprisingly, in swimmers, I've seen a lot of rectus tendonitis, which can really be a stubborn tendonitis to get rid of, and I've even gone to injections for that sometimes. And finally, I don't see a ton of Achilles tendonitis in kids, but there's a fair amount. The younger kids, we'll get to that when we talk about Seaver's disease, but see a swollen, fusiform swelling of the Achilles tendon, or they hurt over it and things like that. And the tendinopathies, I mean, you all know how to treat. I try to give them a period of rest, try to take some tension off of the tendon. With the patella tendons, you can use a Chopard strap. For the Achilles, I put some heel lifts in their shoes or something like that. I do try to get them, to come in and see the trainers or the therapists and get local treatment to the tendon. And again, this is a younger population, but, with the news media and the amount of information that's out there, I've actually had parents, kind of request PRP injection for these problems. And of all these tendinopathies that I have here, none of them are really amenable to a cortisone shot. Not that I would give cortisone to kids this age, but I'm also a little hard-pressed to say I'm going to give you a PRP injection. My answer is take your child out of sports and stop for a little while. And I understand the kid's desire to play, and I understand the desire of the parents to have them play, but that's really kind of my main message to them all is, this is a sign that your child is doing too much or working too hard. Muscle strain injuries, chronic muscle strains in kids, again, they're there. I think the most common ones that I see are proximal rectus injuries where, again, it seems to be soccer players most frequently. And when I see those, I get a little bit worried about femoral stress fractures, so I start to work them up a little bit harder. And then hamstring injuries, I don't really get too overly concerned about, and they usually get resolved with rehab. And then I know why I call this apophysitis, because I call apophysitis a mixed overuse injury, but I think it is because it's a tendon insertion on a growth center. So it's a combination of tendon and bone. And obviously the one that we see, more than anything else is Osgood-Schlatter's. They hurt right over the tibial tubercle, and the kids are saying after practice, they're limping off the field, and all you have to do is press on their tibial tubercle, and you know what the diagnosis is. I rarely get x-rays, I rarely get MRIs on that. But again, I tell the parents it's one of those things. This is just a sign that your child's working a little too hard. They need a little bit of rest. I do try to put them on extensor mechanism, stretching, ice massage, and things like that. Seaver's disease, I went through that with half of my football team. So everyone was going home and ice massaging their Achilles insertion and putting in gel cushions in their feet. The gel cushion isn't to cushion the heel, by the way. The gel cushion is to lift up the heel so you take a little tension off, and they're all doing the wall stretch and stretching out their Achilles mechanism. The one apophysitis that I see a lot more of than I think I should is iliac apophysitis. So I see a lot, especially track runners, and it seems to be much more common in females than males. But they come in and they say their hip hurts, and when you ask them where the pain is, they put their fingers on the anterior 1/3 of their iliac crest. And they're really in a lot of pain. If they do a hip straight leg raise or a hip abduction, you might generate some pain in there. It seems to be much more common in the sprinters. And I've had a couple cases, like this case, I got an MRI, and you can look at the edema in the marrow of the iliac apophysis there. Sometimes you'll actually see a little hypertrophy of the apophysis. They outgrow it, but again, it's just something they have to kind of work on some hip stretching, but the gist of it is they have to kind of cut back a little bit and let this thing get better and work through the symptoms. So I think, what I'm trying to drive the point home is that overuse injuries are very common. It's a big part of my practice. I think it's a very big part of primary care physicians' practices. And I think the ones that have a genuine interest in sports medicine, they recognize the injury. The ones that don't, they say, oh, it's growing pains, and they kind of laugh. They tell the parents and the kids, well, to stop playing for 6 weeks. And that kind of cavalier approach towards it just turns the parents and the kids off totally. They're like, that guy doesn't know what he's talking about. He doesn't understand how important this is to me. When I talk to the kids and the parents about taking time off, it's with the understanding, I know they don't want to stop. And I don't want them to stop. I just want them to cut back and be more realistic about their expectations. So, we know that these injuries are risk factors for future injury because the greatest risk factor for having an overuse injury is a prior overuse injury. In certain injuries, there is a risk for degenerative changes and osteoarthritis later. It's not that big of a deal. I think that gets a little bit overblown, but I think we use it as a tool. And I think probably one of the worst things is it may lead to avoidance of recreational exercise. How many kids that go out for the track team do you see get run into the ground and they quit? And then they never go out for another team again. And what's their last memory of running? That it hurt, it caused them to get injured, and they don't like it. And then they get older, and now they're 20 pounds overweight, and they hate exercise. It's just that's the wrong message to our kids. So again, I think athletic trainers are at the forefront of this. I mean, you're the people that recognize these injuries first. I think it's the trainers that get the kids to go to the doctors. And I read this article with a lot of interest. This was in 2011, the position statement on prevention of pediatric overuse injuries. I think their recommendations go right along with the needs that I brought out on stress fractures. We need some form of national injury surveillance system so we can start to get some real data. Because why do we need that data? We don't just want to collect data for the sake of data. We want to identify risk factors. Can we find out which kids are at risk and prevent these injuries? By improving the quality of the pre-participation exam, that should lead to, help us identify some of the risk factors. Proper supervision and education points to the coaches, to the parents, to the rec coaches about learning these things. Sport alterations, making rules like you can't play on 3 teams at once. The problem is those rules can be difficult to enforce. Training and conditioning programs that maybe aren't as high impact, so that when a kid's out for the soccer team or the track team, maybe they're doing some non-impact aerobic training or some stretching or something like that. And trying to encourage families that delayed specialization is the way to go. Again, we don't have the hard data. I can't stand up here and tell you with statistical significance that early specialization leads to injuries. But I think we all think the same thing, right? So it is a real problem. We know that 70% of kids participating in organized sports drop out by age 13. That's right around the time that they're getting towards high school. We know the sports injuries are on the rise, and I think everybody can help. And I was actually a founding member of this sports trauma and overuse prevention program. It's called STOP. I think over the last 3 years, they've become more and more in the forefront of the media. The NATA had a part in this. When I was at the first meeting, it was a roundtable discussion, like what's the mission of the STOP program? And it was orthopedic surgeons, primary care sports physicians, therapists, trainers, pediatricians, everybody. And I can tell you, to a person in the room, the answer was, we've got to bring fun back into sports. That we can't, using sports as an ends to a mean is not why, we're taking care of young athletes. And so they've gone through this entire media blitz. I think it's been very effective. It seems to be generating steam all the time. I think they're even taking some time in the Olympics to advertise it. If you go online, they have all kinds of interactive sports tips, games for the kids, educational things for the coaches, the parents, healthcare providers. Everybody can benefit from going to this. So I think it's something it's worthwhile sending your patients to, your parents to. So it's stopsportsinjuries.org. Put the sign up in your training room, whatever the case may be. I mean, everybody who goes to this will benefit from the information on this website. There's a lot of other, organizations, Safe Kids USA. They're all kind of working towards the same theme, but I think this really is doing an outstanding job. So I hope I got my message of having fun with sports across. Thanks for your time. Any questions or comments? There's no data to support that. And again, that goes back to the paucity of data on pediatric and adolescent athletes. We just don't have those numbers. That's kind of what I'm driving at. It would be great to know that answer. Uncommon that they work it up. I agree 100%. I think, number one, a lot of orthopedic surgeons really don't like taking care of stress fractures because you can't operate on them anyway. And so they kind of say, oh, stop playing, and they hope you'll go find another doctor. That's one. And I think that is just starting to catch on now. For instance, there was another good article recently that showed if you looked at vitamin D levels and bone density in kids with stress fractures, that the kids who had higher vitamin D levels, had a lower, higher vitamin D intake, had a lower incidence of stress fractures than the rest of the kids. But there was no correlation with bone density and the risk of stress fracture. So I think we need to call that data out right now. But I do that. Like, I know exactly what you're saying. So for instance, the girl that I was showing you the case of, she's my patient. She's already had a DEXA scan. She's already been to a bone metabolic specialist and had her vitamin D levels, her parathyroid hormone tested, and everything. And the truth of the matter is everything's normal in her. But the fact that she plays on 2 soccer teams, 2 track teams, and swims probably has more to do with it than anything else. But, and again, that's something, again, as trainers, I think that's one of your roles. You can say to the child, or if their parents come into the training room, this is really taking a long time to get better. I wonder, there could be something wrong, and maybe you need to dig a little bit deeper. But finding the right person to send them to who's going to take the time to do that, I've struggled with finding like good bone, like a metabolic specialist for bones who will do the right tests. But it's a great question. It's just really incumbent on the people that have an interest in this particular problem to drive our patients in that direction. Yeah.
Considering the couch potato kid that doesn't play anything all school year, like out in spring track, and your athlete who's been playing basketball all year round, they both present themselves with, let's say, patella tendonitis. Treat them differently? Is the diagnosis the same?
Well, the actual hands-on treatment is probably the same. The kid who's played basketball all season long and then comes out for track, I'll say, look, you probably need to cut back because your body, you didn't take a break in between seasons. So in addition to the hands-on treatment that I'll recommend, I'll ask him to cut back for that particular reason. The couch potato who comes out and develops patellar tendonitis, I'm saying your body can't go from 0 to 60 overnight. So you have to cut back, but it's for a different reason. You need to kind of bring yourself up to speed more gradually. You try to get in shape overnight, and this is the problem. So in the end, the 2 athletes are treated the same, but my explanation as to why I'm treating them the way I'm treating them is dramatically different. And I think they appreciate that. All right, thanks a lot.